Hi everyone, I'm Jim Lee, Sheffield GP. I work as a peer advisor for cases gastroenterology, and delighted to be joined today by Professor David Sanders. Yeah, thanks for joining us, David. Could you maybe just tell us a very little bit about yourself before we get started?
Yes, of course. I thank you for the invitation. I work here in Sheffield, like you. I've been here for about 3 decades, so I'm old and coming to the edge of the world. But I have been involved in this field for a long time, and Sheffield, by chance, is the NHS England National Centre for Refractory Coeliac Disease.
Right. Okay. So obviously, celiac disease is a fairly common condition that we see a fair bit of in general practice. Just wondering what the prevalence of this is in the community and how much of it is actually diagnosed at the moment.
So 1 in 100 people have got celiac disease, pretty much globally, and this is a huge misconception from 20 years ago when we thought it was really uncommon. So it is literally the most common GI condition. Currently in the UK, for every case that you recognise, there's probably 2 that you don't. And a major reason for that is that the construct of celiac disease has changed in our minds from what we were taught at medical school. And if I put this to you, maybe a suggestion, which is that you eat gluten, you don't know you've got celiac disease, you've got the right genetics to develop it. When it lands in your small bowel, this is when you get the inflammation and everything else unfolds. But if you think about something like that, then almost any gut symptom could give you celiac disease. And by that, I mean heartburn, bloating, not typically what you might have in your head of, oh, they must be losing weight and have diarrhea and have signs of malabsorption. Mm-hmm. It's much more subtle. So for me, point 1, if you've got any gut symptoms, you're in the park. Point 2 is, remember that you've got this destruction of the lining of the bowel, so suddenly you're not absorbing things properly. And that's all hematinics, whether it's iron, vitamin B12, folate, vitamin D. So again, seeing somebody with iron deficiency anemia or any such malabsorptive condition, think about celiac disease. It'll be incredibly common. You've got a 1 in 100 chance straight away. And then the other 2 I'll throw in there are family history. If you ask somebody, and they've got a 1st-degree relative, then their risk goes from 1 in 100 to 1 in 10. And for 2nd-degree relative, it's probably still something in the range of 1 in 3, 2.5%, 3%, something like that. And my final point I'd make to you is this is an autoimmune disease. So it's really unique because if you've got type 1 diabetes, then your antibodies attack the islets and there's nothing you can do about it and you need insulin. It's done. But quite uniquely with celiac disease, and bizarrely, if you wish, if you go on a gluten-free diet, you can arrest this autoimmune condition, but it overlaps with every other autoimmune condition. So Jim, if you and I go down to a type 1 diabetes clinic, grab a bunch of people, test them, 5 of them will have undiagnosed celiac disease. So if you come into it in the way I do, because I know you can say, my God, I read about this and every single symptom is related to celiac disease. If you have a different way of looking at it and just say, here's my 4 shots. Have you got gut symptoms? Do you have any hematinic deficiency? Is there a family history in your gang, in the patient that you're seeing? And have you got other autoimmune diseases? Then I think your hit rate increases without feeling that you're just doing it on every single patient that comes to clinic.
Yeah. Okay. That's helpful. Are there other than the classic, so you've kind of things about history there, but what about in terms of other kind of clinical presentations other than the GI present? I'm thinking about things like fatigue and more vague things like that we see a lot of in general practice.
So I would say to you, if you've got someone with fatigue and you know that celiac disease is a common cause of hematinic deficiencies, I suspect you're almost certainly going to do the hematinics in a person who comes recurrently with fatigue. And if they're low, then celiac serology is literally £15-20. It costs you nothing to throw that in. But I don't, I suspect you and I are both feeling tired right now. It's a Friday of a long week, so I'm not saying But I'm kind of saying, if you have it in your head that you've got these 4 key points, it'll make it easier for you to just ping the test when you think it's appropriate.
Yeah. Okay, great, thank you, that's helpful. So obviously in Sheffield, certainly in general practice, when we open up ICE and go to request tests, if we request celiac screening, we get an anti-TTG test back. Is that a test that we can rely on in all situations, or are there certain situations we need to be thinking about other ways of testing for it?
It's a fantastic test.
Cool.
It's really got a strong positive predictive value, but there are a few caveats to that. The first is that all the celiac serology, whether it's endomycelial antibody or tissue transglutaminase, they're all based on IgA. So if you're IgA deficient, then no matter what, you'll give a negative test. Okay. But usually you hope your immunologist will be onto that and will point out to you, or something, because you almost get a 0 level rather than a slight signal. So that should put you in that park. The second thing I'd say to you is that serology negative celiac disease does occur. It's uncommon. It might be as little as maybe 3% of people presenting with celiac disease, but it is a genuine problem, and it particularly occurs in people who are either early in the disease or have a family history, or are late in the disease and have been overwhelmed. They usually look very sick. So it is out there, and of course other things can affect the antibodies. So if you're on other immune therapies, that will dampen down your IgA level, and so on. And the final and possibly the most important thing that goes wrong is that people may have already reduced their gluten by speaking to other people, chatting, saying, oh, I've got symptoms or whatever, and then they cut down the amount of gluten that they eat. And just to give you, gluten is 2.5 to 3 grams in a slice of bread. Most people eating 10 to 15 grams. So when they come to you and you're thinking, just check that they are still eating gluten, that haven't made that change. And sometimes we see that actually we then go on and say to them things like, oh, well, it might be a while before your camera test, so why don't you make a change now and see what happens? And that's a disaster. Please, whatever you do, don't do that. You can just refer them directly to the celiac centre here at the Hallamshire. They'll get done within a matter of weeks. So it is just a straight referral straight in to me by name, or to the NHS or the National Centre. And the referral finds that we have a dedicated pathway. Every Tuesday we have a list of people with positive serology who get biopsied. So please don't tell your patients to continue eating gluten no matter what they're doing.
Yeah. Okay. So are those patients going straight to test, or do you see them in clinic first?
No, they come straight for an endoscopy. If you write to me and say this person's got positive tissue transglutaminase antibody, I will arrange a gastroscopy, which will happen in general. I know there's certain issues within the trust right now, but will happen usually within 6 weeks. And if you're worried, if you think, oh, 6 weeks is a long time, this person's losing weight and diarrhea and everything, just email me on david.sanders1@nhs.net, or you can call me, and I can accelerate that and do it within a matter of days.
Wow. Okay. Well, that's good to hear, because I think that is a worry of a lot of GPs, is kind of leaving people be kind of having gluten and struggling with symptoms for months and months before being tested. So that's very helpful to know.
And I understand the confusion, Jim, because if you look at gastroscopy referrals, it'll come back from the general pool saying, oh, you're going to wait for 3 months, 6 months, whatever.
Yeah.
But not the case for people with positive serology. So that, in this new world we're living in, we can still communicate with each other and bypass pathways. We can make things work.
Okay. So I guess important for us maybe to prepare patients for the fact that they may be going straight to test, and not necessarily having a clinic appointment with someone first.
Absolutely.
Yeah. Okay. And one thing that kind of seems to become a bit more prevalent, I've been hearing more about recently, is the kind of non-biopsy approach to celiac disease. I wondered if you could just tell us a bit about that and when it might be appropriate.
Of course. So if you have a tissue transglutaminase, let's say the normal range is 0 to 7, and if your patient has a level that is 10 times the upper limit of normal, so greater than 70 and onwards, then the correlation with villus atrophy is in excess of 95%. And of course, you and I would both say, have we ever met someone who said, thanks, doc, for arranging that gastroscopy? You're my favorite GP or gut doctor.
Yeah.
No, thanks you for that test. So this is a way of reducing the burden, making it a shorter patient pathway, all of the above. But it does have to be handled really carefully, and I still strongly recommend that they are all referred, and this is what the guidelines will say next year, that they are referred into secondary care. That way they still get all the things they should get, whether it's a dietitian or everything else, and they get that discussion, because some of them may not be comfortable with having a blood-based diagnosis. And the greatest fear I have is that kind of law of unforeseen consequences, which is, here am I doing, knowing more and more about less and less, just doing a tiny little bit, whereas you guys are doing everything out there in the real world, right? So the danger here is that your patient will have a slightly elevated TTG, and suddenly they'll be putting themselves on a gluten-free diet or ending up on a gluten-free diet, and that chaos could out of this. So that's why my view is any positive serology should be referred in, even tenfold. And then that way they'll still be in the pathway. Your patient will still get a good service, but they may not need a gastroscopy.
Yeah. Okay. Fine. That makes sense. Yeah. Good. Okay. So then once these people have had a diagnosis, obviously gluten-free diet is a key part of that. So do you guys always refer them directly to the dietitians before they come back to us in primary care?
Yes, the pathway here is we have a dedicated dietetic service. They get seen at the point of diagnosis when we've got histological confirmation. Then they get seen generally 6 months later. The initial consult is a group clinic because they're all kind of being sworn into gluten-free, so it's the same info. We signpost them to Coeliac UK. If appropriate, we arrange a DXA scan. We're waiting to see what the outcome is for gluten-free on prescription. There's an ICB thing ongoing. And then in the forthcoming guidelines, we'll just be asking for pneumococcal vaccine, nothing else, just that. So there's a sequence of events that occur to the patient with lots of education, and then they come back with their bespoke problems. I might say, oh, I really like eating paratha and chapati. What am I going to do? What am I going to do? How am I going to survive? You might say, it's very difficult because I've got type 1 diabetes and I'm trying to manage it. So that second appointment is really bespoke for the individual. We're currently working on, hopefully by next year, a national webinar which gives everybody the first patient appointment and therefore reduces that dietetic workload, and it allows the equity of access because it means everybody can have a look at it again and again. There will be languages such as Urdu and other options, Polish and so on. So I'm hoping that will improve things further still for our patients. But that would be the pathway. And then if we're happy, they get discharged. They don't need regular follow-up in secondary care, but and there's no real evidence base for that, but I certainly think they should be able to access the service again if there's problems. And my view is, if you've gone onto the gluten-free diet, you understand it, you're well, you feel better, bloods and everything is going in the right direction, there's nothing more that's needed. You don't necessarily need a biopsy to look for remission. It becomes an individual patient basis. And I think that most patients, if they understand, they'll take control and have agency over their disease and will run it for themselves. But they must have an access point to secondary care, and we make sure that that's present in the letters.
Okay, great. And what would you suggest we say to a patient, say maybe someone who we screen because of a family history or because of an autoimmune condition who might not necessarily have many symptoms that we would attribute to celiac disease? If they're saying well, why should I make this huge change to my lifestyle and my diet for a condition that I don't think is causing me symptoms, what would be a good response to that?
I think what I would say to them is, I appreciate you don't have symptoms and we've tested you for these situations, but at least go to secondary care and have your appointment and have a discussion with them about what your options are. The thing about celiac disease is it's a multi-system disease. So for patients who present in this way, they may not actually know how sick they are. They may be living with it for a very long time without realizing it. At the century, I ran a screening study, and you can imagine I had some doubts about this because I was doing it for research. And I diagnosed a number of people who said they were healthy volunteers, came back with celiac disease. 12 months later, the majority of them said they were better. And of course, I kind of said, what do you mean by better? And they would then say, well, I'm busy, I'm a policeman, and I've got young kids, and life's hard. But suddenly I'm energized. I used to come home and sit on the sofa. I had no idea that I had celiac disease, and I feel so much better. So they had accepted their premorbid state. And you then found that they had some hematinic deficiencies, or they then volunteered that they had a bit of abdominal distension or pain that they ignored, or they then come out of the woodwork with all of these things. So I think that it's a question of giving them the knowledge so they can then make an informed decision about where they want to go. And I have no problems with that. If someone said, well, I'm choosing not to do this because I feel fine, at least then they don't go around the wheel all over again getting tested. If they come to you saying, I feel fatigued or I've got tummy pain, at least you've got a putative diagnosis and you can say, this is where you're at. You now decide how you want to go. Of course, we can talk about long-term complications, reduced bone mineral density, increased risk of gut cancers and all of those things, and they're all quite modest. But for me, they seem very ethereal. I want to know if I'm going to feel better. So I can't think about something that might come to me in 30 or 40 years. But that's how I document it all when I see these patients.
Okay. Yeah. Thank you. So once these patients have kind of had their workup and diagnosis and seen the dietitians and been discharged back to us in primary care, you mentioned kind of bone density. So just thinking about that and kind of general monitoring going forwards, what would be the kind of things that we should be thinking about as practices as kind of doing for these patients?
So we do the baseline DEXA scan, and then usually recommendation comes from that, and about 5% of them will have a reduced BMD. But you hope that will improve now they switch to a gluten-free diet. So that's the first point. For monitoring thereafter, the truth is there's no evidence base, but what I worry about are people disappearing off the grid. There are certain people that you want to keep an eye on, people who you think aren't going to adhere, depending on the wealth of the surrounding area in your practice, there will be a difference, isn't it? So you worry people who have an inability to afford the gluten-free diet, 4 times the price of normal bread. So concern. Then if you think this person actually looks a bit sick, they lost a lot of weight and have got diarrhea and so on, somebody you might want to keep an eye on. If someone, and no one's going to know their patients better than people in general practice, they are the true physician, right? So basically, if you think, I don't like the look of that guy, I'll hang on to him. You'll also know people who are able to manage it, and they'll say to you, I'm fine, Dr. Lee, please, everything's great. And you don't necessarily need to be seeing that you're overwhelmed. You don't really need annual appointments for no reason. But it's judicious. In secondary care, we've created a scoring system that says if you're not adhering, if you're older at the age of presentation, which probably means that you have been ticking along with inflammation for many years, harder to heal. If you've come with diarrhea and weight loss, these are the people we don't like and we want to keep an eye on. So you could pretty much say the same in primary care.
Okay. What about kind of recalling these people for annual bloods and checking their serology and stuff?
So many guidelines recommend that. I see harm in that. I certainly think at 12 months that's worthwhile. Maybe even that's a great point to really see, isn't it? Do it at 12 months. My favorite question is, Jim, you had X, Y, and Z when you were diagnosed with celiac disease. What's happened to you now? and then that opens the door.
Yeah.
7, 8 times out of 10, they'll say, I'm a lot better. Everything's fine. Thanks so much. And then if their TTG falls, it's a great marker of adherence and everything else is fine. Symptoms, feel well, no problem. I don't know if they need annual appointments thereafter. I know that many guidelines recommend that they do. I think it's more about you guys using your spider sense about whether you like the patient's look or not, or whether you think you want to hang on to them rather than annual appointments for the rest of their life to say, hi, how are you? Hi, how are you? And are you on a gluten-free diet? Yes. No need.
Okay. Thank you. That's helpful. So just finally, before we finish up, I just wondered if we could just maybe have a quick chat about kind of the how we go about kind of distinguishing and managing people with non-celiac gluten sensitivity, and how we would kind of wheedle them out and manage them in primary care.
So this is the reason that you never tell anybody that you're a gastroenterologist at a dinner party.
Yes.
but also bear in mind that actually, genuinely, some of those patients might have celiac disease, because 2/3 of the people with celiac disease are not diagnosed. So my first starting point is to go all the way back and say, look, if you're going to go down this path, the first problem is you might well have celiac disease. So you need to eat gluten again. And if they say absolutely not, then if you do their genetic testing, which might or may not be available in primary care, I'm not sure. I don't think it's easy. So
I don't think it is.
Fortunately, refer back to me in Sheffield, right? But I would do their genetic tests, and to make sense of that, HLA-DQ2 and DQ8, everybody with celiac disease has got it. But 1 in 100 people have got celiac disease, 25 in 100 have got the gene. So it's only good for an exclusion. If you have the gene, you ain't got celiac disease. That's great, isn't it? Because that gets you not having to put this patient through a gluten challenge and so on. So that's step one. Then we ask them to eat 10 grams of gluten for 6 weeks and do the camera test and the immunology and the bloods and everything if they'll agree. At the end of the day, if you go through that and you're negative and you still have symptoms eating gluten, there is some emerging evidence that there's a separate immune path for NCGS. There's also the fact that FODMAP diet, which I'm sure you all know about and are familiar with, the 1-minute FODMAP diet for IBS is the reduction of onions, garlic, and fructans. And the biggest fructans are wheat. So FODMAP IBS patients go into Pizza Hut and say, can I have a gluten-free pizza? Because that's the way of ensuring they drop their FODMAP content. So there are many people who've reduced gluten for different reasons, including lifestylers, which obviously we want to very much suggest that they shouldn't be doing that. But I think if people have symptoms related to gluten, then first step, exclude celiac disease. Second step, tell them, great, you haven't got that. If you find benefit in reducing gluten, it reduces your IBS type symptoms, you feel better, and maybe in the future there'll be a test for NCGS, maybe so. But that's how I would handle it.
Yeah, fine. Yeah, so definitely worth trying to make sure we've got serology done on a gluten-containing diet.
Yes,
before we make that diagnosis. Great. Fine. Well, that's all been really helpful, David. Thank you for going through that. It's a bit of a whistle-stop tour of a very big subject, but lots of really useful bits of information in there. So yeah, thanks very much for your time, and hopefully this will be a really useful listen for some of our local GPs.
That's great. Thank you. Thanks very much. My pleasure.